Beyond Botox, a possible treatment for TMJ? In adults with temporomandibular joint disorder, is botulinum toxin type A an effective and safe treatment for TMJ pain? So TMD is a chronic disorder that affects the facial muscle surrounding the jaw joint, also known as a TMJ, and can result in considerable pain and dysfunction. It's estimated to affect up to 15% of adults, and unfortunately, there's no known cure. Currently, conventional treatment focuses on symptom management through the utilization of occlusal splints, behavior modification, and medications like NSAIDs or TCAs. So why Botox? Unfortunately, not everybody will want to undergo conventional treatments. Wearing a mouthguard every night is no fun, and medications can come with lots of side effects. With the growing demand for alternative therapies, clinicians appear to be getting more creative and turning to Botox as a possible solution. When you walk into a medical cosmetic spa or dental office, it won't be a surprise if you encounter services advertising Botox for TMJ. Likewise, when you go online, you'll easily come across numerous testimonies from patients and clinicians alike, touting Botox's immediate and almost miraculous effects. Originally, Botox was marketed for wrinkle reduction. However, because of its unique ability to block nerve signals to the muscles, it's believed it can additionally help reduce muscle tension and theoretically reduce pain. However, do these theories and testimonials hold up? In looking for the evidence, I began my search with Dynamed and came across a very comprehensive condition summary on TMD. Unfortunately, however, there was no mention of Botox as a treatment at all in the summary. In going down the evidence hierarchy, I decided to try my luck with PubMed, Medline Systematic Reviews, and Clinical Query. It was there that I found 3 systematic reviews. I reviewed all 3 and decided to do my analysis on the most recent systematic review by Machado et al., published in September 2019. Additionally, it was the only SR that contained a meta-analysis. So in this systematic review, it looked at 12 randomized controlled trials containing a total of 362 patients, with a majority 87% female, most with a clinical diagnosis of TMD and previous treatment failure. The authors looked at studies that compared various treatments with Botox, including placebo, low-level laser, facial manipulation, and conventional therapies. The duration of the different studies ranged from 1 month all the way up to a year. The primary outcome assessed pain reduction using the visual analog scale, of which 8 out of the 12 studies used. Based on similarity in time points and the use of placebo, 4 of the randomized controlled trial results were pooled in a meta-analysis. In this analysis, it was found that Botox reduced pain by 1.74 points on the visual analog scale at 1 month post-treatment, but it had no difference at 3 or 6 months. These results were statistically significant with a 95% confidence interval of -2.94 to -0.54 points, but were not considered clinically significant. This is because a VAS reduction of at least 2 points was required to be of clinical importance. Likewise, when the researchers reviewed Botox against the other treatment groups, they found that any improvement Botox had was again only mild and not clinically significant, as indicated by these numbers. In looking at the potential adverse effects, researchers looked at Botox compared to placebo at 1 and 3 months and found no notable difference. The authors of this review concluded that Botox was well tolerated and produced a slight improvement in painful TMD, but that the quality of evidence to support this was very low and that more high-quality trials were needed in order to make recommendations for its use in practice. So what were the limitations? Well, for one, the sample sizes used in the various trials were very small, ranging from only 15 to 90 patients, and the duration of each study was short, most in the range of 3 and 6 months. Additionally, there was a high risk of performance bias, as none of the participants were blinded, and majority of the studies were at risk for funding bias, since 10 out of the 12 were funded by companies that produced Botox. Finally, other patient-important outcomes such as quality of life and functional capacity were not studied. So what about the other evidence? As mentioned previously, there were 3 systematic reviews. The other one was by Patel and published in May 2019, and the other was by Chen from August of 2015. In these other 2 reviews, I found that the overarching results were very similar. Neither could come to a conclusion that Botox was affirmatively beneficial for the treatment of TMD. Its findings were similar to the conclusions that Machado et al. Had, which were that conservative treatments should be trialed first, and that more rigorous design of trials should be carried out for future studies. Ultimately, randomized controlled trials are the gold standard for answering questions of therapy, but unfortunately the evidence surrounding the role of Botox in TMD is lacking and includes mostly anecdotal testimonies and randomized controlled trials of poor quality. Based on the available evidence to date, Botox appears to be only mildly effective for temporarily reducing TMJ pain. While it's generally well tolerated, Botox is far from a cure and will require repeated ongoing treatment, of which long-term safety is not yet known. At this time, there is not enough compelling evidence to support or refute the use of Botox as a beneficial treatment for TMD. Therefore, conservative treatments should be exhausted before off-label Botox is considered.